9 weeks of clinical posting is sure not a joke. I mean, it was full of emotions. There was happiness, joy, sadness, laughter, and even tears. Say hi. Of course, I must welcome you back to my channel. If you are new here, please click on the subscribe button down below to join the family. And if you are a returning subscriber, thank you so much for sticking around with me. I do not take you for granted, and I love you very much. So, getting right back into the video. I and my colleagues did our clinical posting at the General Hospital in Ilorin, and since we are 15 in number, we were divided into 3. That's a group of 5, and we rotated within 3 wards, which are Ward 2, which is the female medical ward, Ward 3, which is the pediatric ward, and Ward 5, which is the male medical and surgical ward. I definitely can't state all the good, because there are numerous good things about the clinical posting, but I personally feel good about these 4 things. Number 1 is the smile and happiness on patient faces after making their bed. It's always good to see. I mean, some of these patients, especially those with wounds, think we insisting on using face mask and hand gloves before attending to them is because we feel irritated by their wounds. But a simple nursing procedure like bed making gives them all the reassurance they need. The relief and joy on their faces after making the bed gives me joy as well. Then the second one is sometimes when everything has been tried or done for a patient and the patient is not responding to treatment and it seems like we are going to lose the patient, and suddenly there's a miracle or the patient suddenly begins to recuperate, the relief and joy that I feel at that moment can be compared to none. The third one is seeing patients walking out of the hospital after being discharged, or seeing them come in for clinic visits all happy and bubbly. It's always a lovely sight to behold. There's this satisfaction that comes with it. Like, it's always very good to see. And the last one is the confidence and satisfaction I derive after perfecting a particular procedure. It makes me feel good. It makes me feel like, okay, I'm learning, yeah, I'm progressing. This is not a bad choice. It's a good thing. I'm trying my best to contribute to people's health. So it's always very good and satisfactory. I'll say being exposed to various kinds of infection is topping my chart here. Yeah, we can't choose patients, or we don't choose patients. We attend to all kinds of patients with various types of infections, and the risk of needle prick or the exposure to those kind of infections cannot be overruled. There was a time like almost a week, the patients I was attending to were all reactive patients. Just have to be careful. But it does not, of course, when attending to them, all precautions will be taken, but that does not overrule the risk of being exposed to the infections. So it's advisable to get some vaccines and shots, for example, hepatitis vaccine. Another thing is soiling. I mean, you can get soiled by your patient at the start of your shift. This does not necessarily mean it happens every time, but you don't know when it will. I was once soiled before. I mean, my feet was once soiled with a full bag of urine. I was not prepared for it. I didn't know it was going to happen. But that does not mean I had to abandon the patient, and it was not the end of my shift. Like, that soiling happening didn't mean that was the end of my shift. I was lucky there was an extra crocs in the ward, so I went to clean up off my socks, my shoe, take care of them, then change into that extra pair of crocs, and my shift continued. So you're not really, you don't even know what kind of soiling will happen. So it just springs up on you, and you take it like that. The third one is dealing with patients' death. It's always emotional. It's exasperating and more annoying that you can't even dwell on the patient's death, because the other patient still breathing needs your attention, needs to be taken care of. In medical wards, you'll be lucky not to have a patient die within 3 to 4 days. Like in 3 to 4 days, I'm not losing a patient in medical ward. It's a great luck. And that's majorly because most of these patients are in their last stage of their condition, or because they don't present their condition or themselves to the hospital at the right time. It's always very late before they come forward to present their condition, and most of the time you really can't redeem their situation. So death occurs almost every time. And in a situation whereby you are dealing with patients with cases where nothing could be done, the only thing to do is to help such patients to peaceful death. The last thing that I feel like it's a bad thing, or I feel bad about, is a situation whereby a patient decides to be discharged against medical advice. That's what we call DAMA. As a nurse, you should probably tell them why, like just a little bit of, you don't dive too much into a patient's affair, and you don't stand by and do nothing as well. There's a balance in between. When after probably your advice or telling them not to go to get discharged, and they refuse to stay back in the hospital, there's nothing to be done. You have to discharge such patients. Meanwhile, the discharge is not going to be done by nurses. Obviously, it's doctors that will discharge such patients. But it's always very sad to see when the patient has given up all hope and decides to go seek traditional healing. Just like one of our matrons used to say, that hospital is not a prison. When they are all set, so their mind is set to living, there's nothing you can do. You just have to, they have freedom. You have to free them to let them go. So you can't do anything to help the situation. The first procedure I tried on a patient was pushing IV medication. It was done under supervision, obviously, but when I am interacting with my colleagues, I realized a lot of us prefer pushing IV meds at first because it seems simpler, easier, and it's very fast. Not until we were lectured about the dangers of pushing IV if you are doing it wrongly or push the wrong medication. Obviously, there are rules to saving medications. You have to check the right medication, right patients, right routes. We were made and the likes, but to know that whatever has been pushed in cannot be reversed, because we are walking through the vein and it's very fast. So learning that, I would prefer to give a medication that can be given intramuscularly and intravenously. I prefer to give it intramuscularly, yeah, except if it's a case of emergency and the patient is in need of that particular medication ASAP, that I will give intravenously, or if the medication is just for intravenous use. I got to witness a lot of procedures, ranging from nursing procedures to medical procedures, some of which are wound dressing, wound debridement, which is the removal of necrotic tissue from a wound to enhance wound healing. Last office, which is performed, that's the last duty a nurse performs to a patient, performs on a patient that has passed on. Incision and drainage. It is a minor surgical procedure done to release pus or pressure built up under the skin. Another one is tepid sponging, which is done, say, nursing intervention done to reduce temperature in a febrile child, documentation, medication serving, giving IMs and IV injections, as well as subcutaneous injection. I didn't get to witness intradermal injection. None of my patients or the patients we saw were in need of intradermal injection, so I didn't get to see that, and I didn't get handing over and taking over of shifts, handing over and taking over of patients at the theater. That is when you have a patient who is in need of surgery. You go with an attendant push the patient. The nurse in charge will go with the files and documents of the patients to the theater. Then you hand over the patient to the nurse in charge at the theater. There are procedures to that. I got to witness that as well. Then building interpersonal relationship with patients. That is very important. I feel like you get to do more of that every day, and you build on it daily, because you meet patients daily, you different patients, then you come back, change of shift and everything. You just get to talk to them, and it becomes better each day. It becomes better day by day. There are many more procedures. I was even lucky to go to the theater with a patient. Like, I witnessed a procedure in the theater. There was this patient with perforated typhoid. Exploratory laparotomy was done at first, but there was a reperforation and re-exploration was done. So I witnessed the re-exploration. It was good to, probably because I was eager and all, curiosity. I satisfied everything in the theater. So there are many more procedures I witnessed, to mention but few. It took me a while before I gave my first IM, because I don't want any patients suffering from injection abscess from me. So I was watching and learning, and when I finally gave my first IM, I did it like a pro. Yeah, it was under supervision, and I began to feel worried when the patient kept rubbing at the site of the injection. But the nurse in charge noticed I was worried, and I kept checking on the patient, so she was like, I should not bother, that the particular injection I give is a painful one. That's why he kept rubbing at the site of the injection. So I was relieved. I never knew wound dressing is very tasking, because I'd been watching and it appeared simple and easy. Not until I tried it. I dressed a tetanus infected wound, and I knew I was doing a very hard work when I started sweating. Like, while at it, I was sweating. My face mask, my face, I was just like, okay. Then my waist started paining me, because you had to bend. I had to bend over to dress the wound. So after I finished and I felt the stiffness in my back, I knew, oh no, this is not a joke. This is not just a simple thing I presume it to be. So that was what I felt. Other than that, it's an easy thing to do. Yeah. Okay. I wish I saw a born patient. No, don't get me wrong. I'm not wishing anybody bad or anybody to get burnt or whatever. Just that, since I have this idea that born patients or born is classified according to degree, to be like, how many degree born, 37, 58, I'm not sure. So I really wanted to know more about borns and how they treat it, majorly because I think it's more common with kids. So when I got to witness that, and there's a case of emergency in the neighborhood, at least I'll be able to render a first aid to such patients. So I wish I really saw that, but I was not fortunate enough to see. Maybe next time when we visit the ward. A lot of my colleagues complained of weight loss during the first few weeks of our clinical posting, but I couldn't relate. And it's quite understandable, because we are mostly on our feet or stand long hours with doctors on ward round. I felt the toll of clinical posting during the 6th week when I had a strain on my right ankle. and it lasted for a week. It was challenging because I felt like a strain shouldn't make me miss out on learning for a whole week. So I went about my shifts throughout the week like I had no strain on my ankle. Attending to children is challenging, and more challenging when you're about to give injections. I mean, their fears, wails, the tantrums, the tears can go overboard. So I'm about to get over my fear of giving them injection at the wrong site or giving it wrongly. So I'm yet to overcome that fear. While in the children's ward, I only gave a 13-year-old an injection, and I'm yet to give a toddler injection until I overcome that fear. I don't think I'm going to. The last but not the least thing I think I have a problem with, or I see as a challenge, is setting IV lines. It can be tricky. Normally, in this part of the world, doctors are the ones to set IV lines or grant patients IV access, but nurses are trained to do so just in case of an emergency, and the doctor is not online right now, rather, can disappear as soon as the needle gets in. So I feel, I don't know, it's more like I feel the pain on behalf of the patient. I know it sounds funny, but I'm yet to overcome that. I need to overcome that so I'll be able to learn that. But these are just the few things I see as a challenge, or I add as a challenge during my clinical posting. So this is all I have to say to you, to summarize about my clinical posting. Hope you pick or learn one thing or the other, and hope you have each free clinical posting too. Before I put an end to this video, I want to make a special shout out to somebody. Her name is Fauzia. She met me in school, called me by my YouTube name, and told me she got inspired by me and came to Alikma Nursing Department because of me. We just started another session, so she's resuming as a 100-level student. Thank you so much for telling me that. It's made my day the day you told me that. In fact, it made my week. I was so happy I was able to inspire someone out there. Thank you so much. I really appreciate you, and I hope you don't regret your decision to come to nursing or come to Alikma University. So if you know anyone interested in nursing or wants to come to a university, this is not an ad for my university, it's not a paid ad actually, so you can tell them to come to Alikma University Nursing Department, or show them my video and comment on my videos, and do remember to share to your friends and family as well. See you guys in the next video. Bye.